Thank you, Kathleen. You guys can hear me? All right, perfect. All right, good. Okay, so let's get started. Thank you, everyone over here. I hope everybody got their lunch and all sitting down. I'm glad I'm doing the first one because after the lunch, people may be a little bit like in 15, 20 minutes, feel a little sleepy, but hopefully we'll keep you on your toes and have some time for some discussion, some questions. So as you can see, I named the title A Tale of Two Galaxies here, and I think people are thinking about what's that and what am I talking about. So it's not gonna be a big surprise. It comes from loosely A Tale of Two Cities by Charles Dickens. So I said, well, let's talk about two galaxies in our world and what do they mean to us. Now, when I was putting this headline from National Post, I thought about Titus, because every time I give a talk here, Titus says, man, I'm just scared of going to the ICU every time you talk about the ICU. And I said, well, and today I said, well, maybe we can show you certain things that even if you go to the ICU and you come out of it, it may help improve the quality of life after surviving the ICU stay. So this was in the National Post. This was the experience of one of a physician, not a physician, she's a PhD doctor in University of Toronto. She was admitted in the intensive care unit because of bacteremia, septicemia, which is overwhelming infection. She needs to be on mechanically ventilated. She was in a coma for a few weeks, and then ultimately she was discharged. But that's how she recalled her experience. Blood seeping from the walls, killer doctors, and then they say ICU hallucinations haunt a staggering number of patients. And let's see what she was experiencing and what was the hallucination that was happening. So this is what she was looking at. It says that the doctors were standing in the corner of Cheryl Mizek's room, wearing little Christmas party hats and getting more and more drunk. Then they stripped naked and paraded the patients around the intensive care unit one by one, taunting and humiliating them to their giddy delight. This was her experience, and this was her quote, she said. So what is exactly happening in the ICUs and what is happening post-ICU? So let's look at this snapshot from the 1990s till 2016, or now 2018. And what has happened that in the 1990s, people were admitted to the ICUs and there was a really high mortality at that time. I mean, take acute respiratory failure, or ARDS, as an example. As one of the diseases that affect your lung, you're unable to breathe, you have to be on the breathing machine to survive. The mortality rate was up to 40%, 50% before 1990s. So there are a lot of people dying. Now, what we have learned over the last 20-some years, we have come up with certain techniques in the ICU to reduce the mortality rate down now to 14%, 15%. So a pretty significant achievement. But because of that, and then because of the higher number of people getting admitted to the ICUs, we have a large number of ICU survivors coming out of the intensive care unit. To put into perspective, there are 5 million admissions in the United States annually for acute respiratory failure. And you can calculate how many of the survivors if we factor in 10 to 14% mortality rate in the intensive care unit. So what exactly is happening in the ICU? So there, on this diagram, I would like you to focus on a few things. So when they're in the intensive care unit, they're getting exposed to pain, right? They are on the ventilator, they have a tube down their throat, people are scrubbing them, turning them, sticking needles into them. They're anxious. And then they develop this thing called delirium or confusion, just to put it in simple terms. What we call it an acute brain failure in the ICU, that they develop this thing called acute brain failure. They are confused, they're inattentive, they don't know where they are, they cannot follow commands. So think of delirium as we go forward. The other things is they are hypoxemic. Obviously, they come in with some comorbidities. They had mechanical ventilation because of hypoxia. We are giving them multiple medications to keep them sedated, or we think that we are keeping them comfortable on the ventilator. And then they have all these sepsis, ARDS, and immobility, etc. And then all these multiple arrows, they go and they develop this constellation of symptoms around the time of discharge that could persist up to 5 years after discharge. Or at least we have data up to 5 years in acute respiratory failure survivors. They have problems in their brain function. They have problems with their depression, anxiety, post-traumatic stress disorder, and obviously they are weak. To just put into perspective, if you're on a breathing machine for 24 hours, you start developing muscle atrophy within 24 hours. 48 hours afterwards, you can have problems which can be diagnosed on a standard test of movement and walking. So keep this schema in your mind as we go forward. And now, one other thing, this cognitive impairment, I mean, we used to think that this dementia-like syndrome is only going to develop in elderly people, 65 and older. So we are seeing it in younger population, people in their 40s. So as young as 40s, as young as 35 sometimes. All right, and all of that affects, obviously, their quality of life as they come out of the ICU. And this is what it is, the post-intensive care syndrome. These are all what you can see in patients coming out. They have mental health problems, as I said, brain function issues, physical impairment, decreased quality of life, but it also affects their families, the loved ones who are taking care of them. So up to 50% of the loved ones have feelings of depression, anxiety, and sometimes stress symptoms. They are unable to go back to their jobs so that they can take care of the ICU survivor as they come out of the ICU. So now coming to the point of those A Tale of Two Galaxies and what exactly those galaxies are. So, you know, I'm a simple ICU doc. I take care of people in the ICU. When I was in the intensive care unit, I met Malaz Bustani. I was a fellow, and Malaz was like, well, do you know anything about delirium? And I'm like, well, people get confused in the ICU, and we kind of take the tube out. They are somewhat confused, and then they go outside the ICU, you know. That was my world, or just put it that way. That was the galaxy I was living in, the intensive care unit. Then we start looking into the people getting out of the ICU, and then there's this post-ICU period, which is a longer period of recovery. I mean, ICU stays like 2 weeks on average for ARDS. The recovery is 5 years after coming out. So you have this another world completely after they stay in the ICU, the post-ICU area. And how the ICU connects to it, we know that, okay, if they have problems in the ICU, they're gonna have problems later. But are we doing anything to help them go through that transition? And this is what we're gonna focus on today and see what has been done and what could be done. So I'm gonna take you through a little bit of a journey. I mean, I've been part of the faculty here now 7 years since I finished my fellowship. And then some of the work that we have done in all these years and how it is connecting the intensive care and the post-intensive care syndrome. So I started my career in the ICU, as I just said, and I started off as a translational researcher, mostly looking at biomarkers, and then start dabbling into clinical trials, did some scales, and then obviously with Center for Health Innovation Implementation Science, start doing some implementation work. So this was the first sort of a hypothesis that we kind of initially come up with for acute brain failure in the ICU. This was the work based on some of Sharon Inouye's work, who's a leading figure in delirium research. And it says that when you have an insult, which is basically sepsis or an infection, and if you have some underlying comorbidities or vulnerability, like you're elderly or you have some pre-existing cognitive impairment, you're gonna have problems in your neurotransmitters in the brain, and it will result in this acute brain failure for longer duration and higher severity. Now, when we were doing that, we were like, well, how are we gonna tell that a person who has this acute brain failure or confusion, how are we gonna say they're gonna have longer problems or longer duration of the brain failure or have problems more severe while they are in the ICU? So this was one of our first studies that we did. We took 321 people. We enrolled them in the study when they were diagnosed with delirium or acute brain failure. We took some blood from them, and then we just followed them longitudinally to see what's coming on. This was one way of trying to basically stratify people into groups or prognosticate the duration and severity. And we got some interesting results, which we are in the process of writing. And we found that certain cytokines, if you look at IL-6, IL-8, they are associated with longer delirium duration. We also found this marker, the S100 beta, which is an astrocyte and glial activation marker, which was shown to have some association, but not any association with delirium duration. And this is some of our work. And we said, okay, if you have S100 beta above a certain number or above a certain value, you're gonna have problems and you're gonna have a longer delirium duration. Similarly, we looked at delirium severity. And in the next slide, I'll talk about a delirium severity scale, which came from our group. And we said, okay, this S100 beta is gonna also show that you're gonna have higher delirium severity or not. And it is showing some promising results at that point. And further, further of interest is not only it is associated with delirium duration and delirium severity, it could prognosticate mortality, especially in hospital, and 30 days mortality while you're in the ICU. So this was some preliminary work we did, some translational work, starting with biomarkers, characterizing patients, and trying to put them into this bucket. The other thing that came out is we built this scale on delirium severity, because when people have this acute brain failure, everybody was like, all right, do they have acute brain failure or do they don't have acute brain failure? And clinically, what we are seeing in the ICU, we are like, well, people are not the same. I mean, you can have acute brain failure, but you are looking different than you have acute brain failure and you're not looking the same, So there was a spectrum, and somehow there were no scales available to stratify or characterize that spectrum in the intensive care unit. So we come up with this thing called the CAM-ICU-7. I'm gonna go through it a little quickly here if I can, and it's not moving now. Oh, okay, so it's not showing up on my slide. So this is what the scale was. There are 4 items. We score them, first item 1 and 0, second item 1, 0, 1, 2, third item, and you can see pretty easy schematic. You can do it in a minute. And that way you can characterize your acute brain failure delirium from 0 to 7. And you can look at the classification. Somehow the screen here is not working, so I'm gonna have to look back over there. And you can see that if you have a score of 0 to 2, no delirium, 3 to 5, mild to moderate, and you become severe, this correlated with the another validated bigger item administered by geriatricians and psychiatrists, and also have predictive validity. So combine this with the biomarkers, you can have a little bit of a picture coming out of a patient with delirium in the ICU, that they can have longer delirium duration. You can predict with a biomarker. They can have higher delirium severity, biomarkers combined with this scale. So some way of phenotyping and stratifying our patients. And then this was the big trial that we completed a few years back. The results are under review right now. And we said, okay, we will come up with a multi-component intervention to reduce delirium in the intensive care unit. And this was based on this model that I showed you before. You can see here, there were 3 neurotransmitters, right? Acetylcholine, dopamine, and gamma-aminobutyric acid. So the intervention, the PMD intervention showed what we did in the intervention. We took a low dose of haloperidol so that we can block the dopamine in the system. We reduced the prescription of anticholinergic medications in patients who have delirium in the ICU, and it will try to replenish the acetylcholine burden in the system. And then we reduce the exposure to benzodiazepines. And for folks, benzodiazepine acts on your GABA receptors and causes increase in this GABA. So we said, well, by these 3 components, we can treat these 3 neurotransmitter imbalances and be able to reduce delirium in the intensive care unit. And some results that showed that if we apply the bundle and continue to apply it throughout the stay, you can reduce delirium coma-free days, which is a surrogate of delirium duration. So you can improve delirium duration or reduce it by 2 days, and you can reduce delirium severity. And there's some signal over there on the secondary outcomes of mortality. So this was some of the clinical trial / biomarker work. Then the other thing, as we were in the ICU, and we said, okay, we have to do something clinically before we publish the results and implement. Why not we start implementing certain things that have worked in the past? So we said, okay, if you're in the ICU, you are sedated, why don't we stop the sedation and see if you can wake up? I mean, people were like, well, you're gonna wake them up, they're gonna be stressed out and stuff. We're like, well, let's wake them up, let's see how they react. So we implemented this program in 2011. Anybody who admitted to the ICU, their sedations and medications, analgesic medication, were stopped in the morning. They wake up. If they are comfortable, they stayed that way. If they're uncomfortable, the medication was started at half of the dose, not at the complete dose. Right? And what we showed, I want to focus on the acute brain dysfunction part here. You can see that the acute brain dysfunction, although not a big drop, but it still was statistically significant. And when you put it in the model, you can see that we were able to reduce it after adjusting for changes and certain things that happen and age and other Apache illnesses, that we were able to reduce acute brain dysfunction by just waking them up, having them breathe spontaneously, and trying to get them off the ventilator. So these were some of the things that we were doing in the ICU at that time. And then we were wanting to see some of the downstream effects and say, okay, we implemented these things, how are we gonna follow those patients later on to see if are we making an impact in the long-term recovery? Now let's go to the other part of the Tale of Two Galaxies, the post-intensive care unit. Here you can see I put implementation science first. So somehow when I started my career in the ICU, started as a translational clinical researcher. When I started working in the post-ICU world, thanks to Malaz, I started off as an implementation person and say, okay, let's just start with implementing a program, because by the time we go test out, stratify things, it's gonna be 17 years and we won't be able to provide any new models of care to the patients who are coming out of the ICU. So we implemented the first ICU survivor clinic in the United States called the Critical Care Recovery Center. It was thanks to Eskenazi Health and their support and the Healthy Aging Brain Care Center that we were able to develop this clinic, focusing only on patients who were on the mechanical ventilator or on the breathing machine for 48 hours and are having acute brain failure in the ICU for 48 hours. But again, this was an outpatient clinic. People get out of the ICU, they either go home, they go to other places. We set up an appointment while they get discharged from the ICU, and then they follow up in this outpatient center. So people who work in the outpatient, who have done research in the outpatient setting, they would know that sometimes it's difficult for people to come to the clinic. Well, we started the clinic. We had certain goals. We wanted to maximize the cognitive, physical, and psychological recovery of these survivors, enhance the patient and caregiver satisfaction, quality of life, and improve the quality of the transitional care, and help them with their appointments, because everybody has like at least 6 appointments coming out of the ICU going to multiple disciplines. And this was based on Chris Callahan's model of a care coordinator, or nurse, or a social worker who would help with the recovery of these patients. So we train our nurses in the clinic and we train our social worker, give them certain tools and say, hey, could you help us take care of these people and implement certain protocols for their recovery, which include brain exercises, physical exercises, cognitive behavioral therapy, problem-solving therapy. But that care coordinator was supported by this big expert team of pulmonary physician, myself, psychologists, geriatrics, psychiatry, rehabilitation folks. And then once they come to the clinic, we do these standardized assessments and then provide the results of the standardized assessment to the care coordinator, who discussed it with the team, create a personalized care plan for the patient, focusing not only on the patient, but also on the caregivers. And this is how our typical encounter looks like. Call a patient, collect the data, they came over to the clinic, everything is standardized, then they see me, I do my doctor-physician thing, which is essentially shaking hands with them, talking to them, finding out certain things. But most of the data that is collected by the care coordinator in a standardized manner and goes into a database. And then after the initial assessment, they come see me in 2 weeks, but when they're seeing me, I have my pharmacist there, I have the nurse, social worker, family members, everybody's sitting on. The plan is getting discussed. The plan is getting input from everybody. And then at the end of that 45 minutes to 1 hour meeting, you have an individualized, personalized plan that is implemented, and then it is followed up on regular intervals for up to a year. And this was a snapshot of some of our initial work. Is we have this healthy aging brain care monitor that Dr. Bustani developed for dementia patients, and I'll show it I'll show that on the next slide. And basically, if you have a lower score on the monitor, it just says that you're improving, and if you have a higher score on the monitor, it shows that you're not. In a pre-post fashion, not in a randomized fashion, it shows that we were able to reduce the symptoms of PICS after discharge from the ICU with the clinic intervention, keeping the limitation that there was no control group. And this is the Healthy Aging Brain Care Monitor. As you can see, it's color-coded. It has a cognitive subscale, it has a functional subscale, and it has a behavioral and mood scale. So think about it. Malaz developed this HABC monitor for dementia patients, right? Dementia people, functional problem, brain problems, mood problems, and depression problems. And here, what I have just shown you in ICU survivor, cognitive impairment, functional problem, mood problem. So you have a 40-year-old manifesting with the symptoms of dementia earlier coming out of the ICU. So we were able to take that scale and implement in the post-ICU setting. And this is just gonna get published, and it got validated with the standardized battery. So this scale can be used actually to diagnose people just based on self-report or caregiver. And think about the scalability of the impact. If you're a primary care place where you don't have an ICU survivor clinic, you add a scale, you do it, you screen them, and you say, okay, you have PICS symptoms, and then maybe they need further care, then you shift them to a specialized place. I'll leave this This is just a comparison with the primary care population, and versus score means, a higher score means worse score. So, and you can see that the scores on the monitor in our population compared to a primary care population was double. If you see, and these are primary care population in an elderly representative sample. Now let's come to what we are doing now and what is the ongoing work that is in progress right now. This is mostly the part where we can say how we can bridge the two galaxies. We talked about the critical care recovery center, post-ICU area. We talked about delirium in the ICU. You guys are getting an understanding of how delirium and things that we are doing in the ICU is not making them recover, and what things we can do in the ICU to probably improve the recovery a little bit or decrease the burden of PICC. So let's see what we can do in between when they're getting discharged from the intensive care unit. So take a model from the ICU, implement it in the transitional phase, and then follow it up in the ICU recovery center. And some of you have seen these slides before. This is one of our mobile critical care recovery programs, which is a randomized trial. It's in the testing phase right now. We are almost halfway done with that trial. What we did, we take our critical care recovery coordinator model from the clinic, and we call it a mobile intervention, because now instead of the care coordinator providing those services in the clinic when the patient physically comes, she goes over, she sees the patient at the time of ICU discharge, and if she cannot see it at the time of ICU discharge, she sees them within 1 week of ICU discharge, assess them with the tools, and then start implementing the intervention or those recovery models right at the time of discharge from the intensive care unit. And then we say, okay, hopefully we can have an improvement in their recovery, and then that would decrease the quality of life. That would improve the quality of life compared to a control group, and that's what we are testing right now. But this is just one scalability concept of how we can take things from the clinic, put them in a process, transitional care, a care coordinator following the patient throughout their journey, right at the time of ICU discharge, till they come either see me in the clinic or their primary care physician or their specialists. Similarly, Malaz is doing a similar program, which we are very much involved in a trauma population, because in the interim, we have started noticing that the trauma patients were suffering from similar problems that are happening in ICU survivors. Although they were not in the ICU, but they had some physical trauma, and that is generating cytokines and other things that can cause them to develop frailty or mental and psychiatric problems after discharge. And then the third thing we are experimenting with is the telehealth program, in which we're just installing certain computers in the homes of the patients, and we have a coach, which is an exercise and a brain recovery coach sitting here in the Regenstrief Institute, working through the internet with those patients at home and helping them do some seated down exercises and brain activities in a group setting, try to get them in 5 to 7 groups of people so they have a social sort of aspect to that. And we are experimenting with that and see whether that would be another scalability of the model. Instead of the nurse going or the coach going home, maybe we can just do telehealth, and that way we can approach more people, especially people who are discharged from the ICUs, live in the rural areas. I'm gonna skip this in the interest of time. This is one of the work that one of my fellows is doing, and I don't know whether he is here, Dr. Golovian, Dimitri Golovian, and he started, he's sitting in the back, he started this ICU survivor support group, and at last, it says 400 members, 374, it's probably more, but this is essentially a chat group of people who suffer from delirium in the intensive care unit, and it's a discussion on basically Facebook that, hey, among themselves, and they can discuss their things, and they can have some comments from us, not as a physician, but certain little things that they can do. They can talk to the doctor about what they are experimenting after coming out of the ICU. So another way to access a bigger group rather than the ones that are coming to the clinic. So if you want to summarize it, and in this slide, you can say, okay, you have the intensive care unit here, which is one galaxy. We implemented these programs. It started off as biomarkers, phenotyping, and clinical trials and implementation. You go to a post-intensive care area where we have done critical care recovery center, try to connect the discharged patients so that they won't fall through the cracks and at least coming to the clinic. Implementing our mobile models, telehealth models, through in the form of trauma med home and mobile critical care recovery center. And then with the use of our care coordinator, Also preventing these people to bounce back to the intensive care unit. And if they come back to the hospital, to do a root cause analysis of why they ended up in the ICU and was there a preventable thing that could have been done to prevent them from coming back to the ICU or coming back to the hospital. That is just one way of trying to provide some holistic care for a person who get admitted to the ICU, come out of the ICU, have a higher tendency to bounce back to the hospital. So few lessons that were learned through the way, and I'm just not gonna delve too much into it, but I thought I would put this quote over there. It was the best of times, it was the worst of times, because obviously, if I'm borrowing from A Tale of Two Cities, it has to start with that, right? So it was the best of times, it was the worst of times. Learned quite a bit. The other thing, learned that aging happens at all ages. I mean, when I was a fellow, I was like, well, elderly, 65 older, geriatrics, you don't have to worry about it. Once these people come to my pulmonary clinic, when I was a fellow, I'm like, whoa, you're 40 years old and you're not able to remember anything. You cannot take your inhalers. Your quality of life sucks. I mean, in a cross-sectional survey of ICU survivors, the one thing they keep on saying, if I cannot remember things after my discharge, that affects my quality of life more than anything else. That's the thing that scares them the most. And the other thing is that 1/3 of them end up developing dementia in 3 years too, those with cognitive impairment coming out of the ICU. So aging happens at all ages. It takes a village. These are pragmatic, complex models, so it requires a lot of interdisciplinary work, not only in the ICU, getting a buy-in from the nurses, OTs, physical therapists, and other physicians in the intensive care unit, also biostatistics and other scientists, Center for Health Innovation Implementation Science, Alzheimer's disease, IADC, all of that, and the healthcare partners. So yeah, it takes a village. There are multiple and community partners and other folks. And lastly, we have barely scratched the surface. We have started to understand delirium a little bit in the last, 15 years, the field has started. The post-intensive care syndrome, we don't even understand. The field is like 5 years old at this time. We're just starting to understand what is going on with them, whether they're gonna recover, what are the things that will help. Can we stratify the patients better? Can we come up with better models personalized for different patients? I'm gonna end with this video, and hopefully it will play. This is one of our patients who was admitted to the ICU. She had a valve replacement, and she had a lot of problems with memory and depression and anxiety, and she was admitted to Methodist Hospital. She actually came to Eskenazi Critical Care Recovery Center, and it was a lot of work. All right, and I would like to take a moment for you to acknowledge the people that are on this slide that have helped along the way. All of this work would not have been possible with the marvelous team that I have, the team Vitality here at the Regenstrief Institute, and all the nurses and the other staff. So thank you, everyone, for making this happen. I think we may have time for one question or a comment. All right, if not, then all yours.